Hello, and welcome to the CAP Today webinar for Wednesday, January 22nd. I'm Bob McGonigal, the publisher of CAP Today, and I'll be your host today, and I'll moderate a question and answer session after our formal presentation. Today's webinar is entitled Aspyre Clinical Test for Lung, a rapid alternative to comprehensive genomic profiling. We're very glad to make this important program available to you today. And I want you to know that today's webinar is made possible by a special educational grant from BioFidelity. A little more about BioFidelity in just a moment. But we want to acknowledge them and thank them for their support in helping us bring you this very special program. Our speakers today are all very distinguished, and let me name them now. Dr. Pranil Chandra is the Senior Vice President and Chief Genomics Officer of the PATH Group. We've worked with him before, and it's a pleasure always. So, Dr. Chandra, we look forward to hearing from you. Also, Dr. NayanJ Sarma is the Associate Director of Molecular Oncology at PATH Group, and he'll be speaking. Our first speaker, however, who will kick us off is Dr. Jeff Gregg. He's the Vice President of Medical Affairs at BioFidelity, and he's a professor of pathology and laboratory medicine at the University of Nevada School of Medicine. One of my favorite schools, and a very, very good one, by the way. So it's a real pleasure to welcome all three of you gentlemen. Before we begin, I want to give you a few housekeeping tips, as I usually do. You'll recognize that we have something of a different format here, but we still have live help available to you at any time, so that's easily found. We'll be doing question and answers, as I said, after our formal presentation. And once we get this recording approved, we should be posting it in about a week at captodayonline.com. You can review all the audio and all the slides. You can expect to get some follow-up email, both from us and from BioFidelity. So just be aware. I want you to know that. Finally, as I always say, CAP Today does not endorse any product or service that may be mentioned today in our webinar, and any comments that I may make are purely personal, and of course not to be taken as the official policy of the CAP Today or the College of American Pathologists. So now I'm going to read you just a little bit of an intro about BioFidelity. It's a relatively new appearance on the scene and a very welcome one. BioFidelity is a genomic technology company dedicated to improving and extending the lives of patients with non-small cell lung cancer by enabling better targeting of therapies, early detection of treatment resistance, and routine monitoring of treatment response. Molecular profiling of tumors is critical for patients with lung cancer to assess personalized oncology therapeutics, both in early and in late stage disease. We at BioFidelity developed simplified genomic profiling technology to provide rapid, and by rapid, we're talking 2-day turnaround, rapid, accessible, and cost-effective diagnostics, informing the actionable genomic variants. BioFidelity has a pipeline of products, and there's 2 products currently available. The Aspyre clinical test for lung, of course, is today's topic. And you should also know that Aspyre has lung reagents available for research use only. Today, we'll discuss the real-world experience with the approved Aspyre clinical test for lung at the PATH Group. And so with that, now I'd like to invite Dr. Jeff Gregg to begin today's formal presentation. Dr. Gregg.
Thank you very, very much. And I really appreciate everybody that's on this webinar for joining us for this hour. And I hope you get some incredible knowledge out of this. So I'm going to start with something that we all know in the pathology word that lung cancer is really a paradigm for molecular diagnostics and precision oncology. It really is the first to kind of jump onto precision medicine. And really, why is that? It's because lung cancer is driven by very specific oncogenic drivers. And approximately over 50% of lung cancers have targetable alterations. And it is so critical for us to go and test for those so that we can get our patients onto those targeted therapies. And you can see here in the pie diagram, we have a number of alterations, and there's 11 to 12 different alterations that are really important to go and test for in non-small cell lung cancer. And as a pathologist, I kind of consider not only lung cancer as a histopathological diagnosis, but it's a molecular diagnosis. And going and putting together that histology and the molecular information is critically important to make the appropriate diagnosis of lung cancer so that our oncology colleagues can go and treat the patients. There has been some very nice data, and this is here on the right, where if you go and you look at patients that got genomic profiles before their treatment, they do significantly better than patients that got genomic profiles that weren't available before that first treatment. Therefore, demonstrating that it is so critically important to go and get this molecular information fast and quickly. Moving on, again, in the non-small cell lung cancer space, there's been over 35 approved therapies starting in 2003 through 2024 in this space. And all of these require having genomic profiling done. And I even included the important immunotherapy drugs because it is critically important to have molecular information to go and be able to go and prescribe those. As we all know, patients with EGFR and ALK alterations don't do well on immunotherapy. They do not respond, and therefore those patients should not receive IO if they have those alterations. So as you can see here, really critical to go and do this testing so that we can get onto all these incredibly important therapies. Moving on, really the benefits of precision oncology are really failing to reach all of patients. As we know, and I talked about before, 50% of patients will have a driver alteration that could be treated with an approved therapy. Yet, less than 40% of patients are getting the full complement of molecular testing. And why is that? There's a numerous reasons, but one of the main reasons is that many of these samples are failing testing. There's just not enough material, not enough DNA, not enough tissue to go and do the molecular profiling. In addition, there's high costs for comprehensive genomic profiling that makes it not accessible for everybody. And then there could be significant delays in getting that molecular information and getting that testing done for a number of reasons. And so when you put all of those together, this creates some barriers to getting this molecular information to patients so that they can get onto the correct therapy. So Aspyre clinical test for lung really is a test that addresses some of these critical barriers for patients not getting their molecular information. And so we're going to go through this and demonstrate what Aspyre is and how it can solve some of these problems. So Aspyre is, as we discussed, simple genomic profiling. It really is a purpose-built solution to address these gaps that I've discussed. It sits in between simple gene testing using PCR that has limited depth and sensitivity. And in contrast, it sits in between comprehensive genomic profiling, which is very broad, it's complex, costly, and can take a significant amount of time to run And so we sit right in between that, and we call it simplified genomic profiling. It's, as Bob mentioned, it's fast. You can get turnaround time in 2 days. It's simple, and it's incredibly reliable. And basically, it is multiplex PCR and reverse transcriptase with mutation-specific probes. And I'll discuss this in just a bit. And we use isothermal amplification and detection to go and detect these mutations. So to give you kind of a contrast of what the inputs are for comprehensive genomic profiling, the standard input for Aspyre clinical test is 5 nanograms of DNA and 1.5 nanograms of RNA, which is significantly less than your typical comprehensive genomic profiling test. We require 10% tumor content, which again is significantly lower than many of the tests that are out there. And then with those limited amount of material going into the test, we still maintain a high LOD of 3% for indels and subs, and for RNA, 100 copies and 200 copies for MET14 skipping mutations. So quite high sensitivity, using significantly less material than traditionally is used, which means we can use smaller specimens. And again, looking at our clinical data and this clinical data comes from our CLIA-CAP approved laboratory. Again, DNA, our tissues sensitivity, 3%, 100 amplifiable copies for RNA, and 200 amplifiable MET14 exon. Now, I haven't discussed this in great detail, but not only do we have a tissue-based test, we can use the same test for blood. This blood is collected in PAX-gene tubes. And again, this technology is amenable to creating very high sensitivity for detection of alterations. And so in blood, the sensitivity is 0.3% VAF, 6 amplifiable copies in RNA, and 100 amplifiable copies of the MET14. And again, specificity extremely high, no false positives. And again, these were from our validations for our CLIA lab. This tissue-based data has been published, and we can send you those papers. Then, so just to kind of go through Aspyre, it's one test for comprehensive coverage of all guideline recommended genes for first-line non-small cell lung cancer. The same assay can be used for tissue or blood. It's an assay that has both DNA and an RNA component. So there's no additional cost and time needed for separate RNA analysis. And a very nice aspect of this, the reports are very simple and actionable. It's a 2-page report. We don't have to worry about VUSs and germline alterations to confound interpretation because we're only looking for actionable alterations, and we'll go through some of those. Again, very fast turnaround, which we know is very critical for patients that especially are sick. And in the CLIA lab, our turnaround time is 2 days for 98% of all those patients. These fast results allow us our clinicians to align their treatment plan for that patient. And importantly, as we all know from our experiences, is that you get that first bolus of information from patients. You get the histology, the diagnosis, and you get PD-L1. And with our Aspyre lung, you're going to be able to get that molecular information that would almost be at the same time as your PD-L1 testing. Therefore, you can then go and then determine the therapeutic interventions of that patient almost immediately instead of waiting weeks and weeks. So it's really reliable. And so this test can work on FFPE samples, very challenging samples, perhaps from FNA washes, pleural fusions, and again, we've talked about blood. very high sensitivity and specificity. And again, we can use very small amounts of DNA, RNA, and tumor content. Again, 10% tumor content. Very low QC failure rates. And we have data and papers out demonstrating that we can rescue QC failures from NGS. So that's a really nice aspect of this technology. So how do these aspects really affect the clinical issues? First of all, again, we talked about turnaround times, average 2 to 3 weeks, and therefore we can go and turn around a result in 2 days. So again, we can go and get that diagnosis to that patient with that molecular information much faster. 25% of lung cancer patients fail NGS, and we have proven performance. We have data showing in a publication that we're able to go and rescue 98% of samples that failed NGS. We can use 85% less input than required for NGS. And then most existing assays run on DNA only. And our assay, as I mentioned, runs on DNA and RNA concurrently, giving us the ability to go and pick those RNA fusions up with high sensitivity. So this is the comprehensive coverage of the 11 genes. So we have 11 genes, 114 variants. At the top, you can see the DNA genes that we detect. And so we detect 77 DNA variants. And then here are the RNA genes that we detect, and we detect 37 RNA variants. And importantly, we've done extensive database searches, and we found that we can go and identify about 99% of all the DNA-based mutations listed in the guidelines as reported in Cosmic, and 96% of fusions in ALK, ROS, and RET based on Cosmic, CBioPortal, and the literature. So this technology not only is comprehensive, it really covers all the actionable mutations. I'm going to go quickly through our technology. And just to give you an idea of how this technology works, again, it's a simple DNA and RNA extraction from tissue or plasma using standard reagents. Target regions from both healthy and mutant DNA are amplified using high-fidelity PCR, and RNA gene fusions are amplified using RT-PCR. We then split those across wells in a microtiter plate, and here's the secret sauce that I'll quickly go over. And so the secret sauce are these Aspyre probes. And what we're able to go and do is we develop these Aspyre probes to the mutations that we want to go detect. And so here and here you have wild type on the right and mutant on the left. And our wild type will have a probe that is mismatched. And then into our mutant, the probe will be a perfect match. Then we have a enzyme that goes and degrades double-stranded DNA. And as you can see, with a mutant, we degrade that, and then we just have this mutant probe hanging here. Whereas in the wild type, it's you get a mismatch, so we do not go and get the degradation, and therefore you do not lose this probe here. We're able to go and recircularize the mutant and then amplify it with rolling circle amplification. And this gives us our incredible sensitivity and specificity. And that really is the secret sauce of this technology. I just want to lastly just give you a demonstration of a quick case to show you kind of how this can be applied to patients in difficult samples. So this is a 55-year-old female with a prior history of ALK-positive adenocarcinoma. And the clinical concern here was they had a new lesion that was growing, even though they were on this ALK-targeted therapy. And they wanted to determine if the lesion was a fusion positive and therefore having progression or second primary. They performed a biopsy on the right lower lobe lesion via a transbronchial biopsy, and it's very small. As you can see here, there was only 5% tumor content, and the sample was not amendable to comprehensive genomic profiling because of the limited sample. They sent this to us, and we were able to go and cut 9 slides at 5 microns, and DNA and RNA successfully passed, and we were able to get the result in 2 days, and we found the ALK fusion, therefore suggesting that this patient now was having progressive disease on this ALK inhibitor, and that really informed the clinicians on what to do next. And again, demonstrating that really how the power of this technology for going and really helping patients out when they could not use comprehensive genomic profiling because of just such limited sample. So I'm going to skip this last slide and just move on and move this to Dr. Chandra, who's going to go and give their experience, Path Group's experience, using the Aspyre technology. Thank you very much.
Thank you, Dr. Gregg. That was a very illuminating presentation and really excellent background. So first of all, thank you to everyone. Really appreciate the opportunity to be here and to present to you our experience with the Aspyre clinical test for lung. Before we do that, I wanted to give you an introduction to Path Group and also give you a high-level overview of how we're approaching precision oncology and addressing challenges and opportunities, especially in light of rapid changes in digital pathology and artificial intelligence. And then Dr. Sarma is going to walk you through our clinical experience with the Aspyre test. So moving on to the next slide, Path Group, we've been in business for more than 50 years, and we've developed a reputation in our market as a high-quality pathology and laboratory testing services provider. And through those years, we have built a high-volume, high-throughput practice at scale, offering every aspect of pathology and laboratory medicine to patients in our geographic network. We've also built a diverse client base spanning primary and subspecialty care. We employ more than 240 pathologists and PhD scientific directors within our network, and we provide the full range of professional pathology and technical services to more than 200 hospitals that are part of integrated community hospital networks. And in addition to professional pathology services, we are able to offer our hospital clients comprehensive molecular and clinical laboratory testing at our major reference facilities in Nashville, as well as Dallas. On the outpatient side, we have more than 24,000 ordering providers spanning 25 states. These healthcare providers are physicians, PAs, nurses, nurse navigators, all members who are critically important and who are members of the clinical care team, and who are all consumers of our testing. To support our oncology and clinical provider network across our hospital and outpatient clinics, we have developed comprehensive molecular pathology and oncology services at scale. We have focused over the years on high-value tests. These are tests that improve patient outcomes, and specifically, these assays look for alterations in DNA, RNA, and/or protein, and help to drive and empower clinical decision-making as it relates to diagnosis, prognosis, and/or therapy. These are assays that are very familiar to you, as you can see here, from bread and butter immunohistochemistry services to FISH and conventional karyotyping services to the offering of an FDA-cleared comprehensive genomic profiling panel that we perform on patients with solid tumors. In our precision oncology practice, we champion the adoption of genomic profiling, whether it's performed on tissue or whether it's performed on peripheral blood. And we helped to optimize test utilization through the engagement of local cancer care teams across our network and also through enterprise education. For example, we support the utilization of comprehensive genomic profiling in any patient who has a stage 4 solid tumor because this practice is backed by medical guidelines. In suspected or confirmed myeloid malignancies, we perform next-generation sequencing to assess for clinically meaningful alterations at the point of diagnostic evaluation. So through our practice, comprehensive genomic profiling has demonstrated the utility to find the right therapy for the right patient at the right time. In colon cancer, for example, the presence of KRAS mutation obviates the need for anti-EGFR therapies and spares the patient unnecessarily expensive and toxic treatment. So we are thereby identifying and removing the rotten apple. This testing strategy also allows for cost savings of more than $400 million annually to the healthcare system. We have found NTRK fusions in lung cancer, gastric cancer, and colon cancer. And in these disease states, the incidence of these alterations is less than 1%. So not only are we finding that needle in a haystack, these are patients who stand to benefit greatly from targeted therapy, and in most instances, this is their magic bullet. And finally, in a CK7 positive adenocarcinoma of unknown primary, if, for example, we find an EGFR exon 19 deletion, that strongly points to the tumor being a metastatic lung cancer, thereby yielding both diagnostic as well as prognostic information. Unfortunately, as a community, we are not doing a very good job to make sure the right patient is tested and the right therapy is given. This is now supported by several publications, including the one here. And despite the fact that lung cancer has an extremely strong body of scientific evidence to support and to guide medical decision-making and providing clinical utility for testing and molecular match therapy, this is in fact not happening today in the manner that we would have hoped. In fact, according to this publication, around 64 patients with lung cancer may not receive the best treatment for their disease. And this is due to a variety of factors and practice gaps that are very nicely articulated in this paper that we show over here. Around 18% of patients have an inconclusive or false negative test result. Around a third of patients, 29%, do not get prescribed the optimal treatment, even though a targetable molecular alteration has been identified. As Dr. Gregg mentioned earlier, there is a high QNS rate for patients in lung cancer, especially with core needle biopsies and fine needle aspirations. And then oftentimes testing is not ordered at all in 18% of cases, or the testing is not ordered in time. And I have seen many times in our practice here at Path Group where the testing, because it wasn't originally ordered, it gets ordered later, and then the oncologist or the treating clinician, they want the testing results as soon as possible. And these are sometimes in patients who are just not doing well clinically. I'm aware recently of a patient that came to the ER in the Middle Tennessee area and had widespread metastatic tumor, and we were able to find an EGFR exon 19 deletion. But unfortunately, by the time we found that mutation, the patient had unfortunately passed away. So at Path Group, we are now currently diagnosing over 150,000 cancers per year. And we are in the process of migrating our entire cancer diagnostics practice to digital pathology. In fact, we are scanning more than 2.5 million slides annually and growing that number at a CAGR of 25%. So as you can imagine, and as a result, we are needing to reimagine the delivery of precision oncology diagnostics to incorporate the advent of digital pathology and future potential of artificial intelligence. These promising technologies have the potential to optimize patient care through enhanced diagnostic molecular classification and better prognostic risk stratification, especially in patients with early stage tumors. And then in turn, the information rendered from enhanced diagnosis and prognosis will help to make sure that the right downstream tests are utilized and optimally utilized. These downstream tests could include molecular assays, such as the ones that we've talked about, including comprehensive genomic profiling, tissue sequencing, rapid PCR-based testing, or they could include assays that look for germline alterations. But I would encourage everyone who is in the precision oncology field to really give this some thought, and really in the light of the potential future of computational algorithms and digital pathology diagnostic pathways. The future is definitely very exciting, and I will say that I don't see molecular testing being supplanted by these technologies. Obviously, time will tell, but there is indeed an opportunity to potentially screen for aberrations and abnormalities that really help to refine prognostic risk stratification and potentially identify those patients who would be at high risk for example, for disease progression, recurrence, or metastatic disease. So let's take a bit of a deeper dive and see what this could potentially look like in lung cancer. Using digital pathology and AI computational pathology algorithms, it is likely that we will be able to tell in the very near future with a high degree of certainty whether or not a patient has a clinically significant alteration, whether that's an alteration in EGFR, BRAF, KRAS, ROS1, or ALK, and these alterations would need to be confirmed by laboratory testing. As Dr. Gregg mentioned earlier, we have to get to a paradigm where we are molecularly classifying these lung tumors. So it's not going to be sufficient enough to classify as a poorly differentiated adenocarcinoma with a lipidic pattern of growth, or well differentiated if it's lipidic. But we are going to need to incorporate and integrate the molecular abnormalities and get to a point where this is an EGFR mutated lung adenocarcinoma with increased tumor infiltrating lymphocytes and MET amplification and TP53 mutation. And by doing that, we optimize the diagnostic molecular classification and prognostic risk stratification, especially in early stage disease, and then optimize the appropriate downstream testing. So let's just say we have a patient who has a high likelihood of an EGFR mutation, and this patient has early stage disease. You may want to only follow through and confirm with a single analyte EGFR mutation testing result rather than an expensive comprehensive genomic profiling panel. However, if that patient has abnormalities suggested through computational algorithms that are associated with a high risk of disease progression, that patient may benefit from and be offered some combination of comprehensive genomic profiling, ctDNA testing to either complement tissue-based sequencing or even supplant tissue-based testing if tissue sequencing is unavailable. The patient may also want to consider MRD analysis to monitor for molecular evidence of disease progression. Let's say we found evidence of an EGFR T790M mutation in a patient who's treatment naive. That patient would need to be offered genetic counseling and would need to proceed down the necessary clinical pathway. So that's how we need to be thinking about the future delivery of precision oncology and lung cancer. And I realize that this is very futuristic in thinking, but the current paradigm is not tenable, and there's a lot of opportunity for improvement. And while this may not solve all of the issues that we see today, they do represent opportunities for us to optimize patient care. And for those patients who either have very little tissue, as I alluded to earlier, and or those patients where time is of the essence, the patient may also require rapid testing to ensure timely access to targeted therapy. So with that being said, I would like to hand it over to Dr. Sarma, who will now talk about our experience with the Aspyre assay. Dr. Sarma?
Thank you, Dr. Chandra. So at first, I would like to thank CAP and Biofidelity for the opportunity to present in this webinar. As part of the presentation, I'll speak about a limited sample study that we at PATH Group performed in collaboration with Biofidelity. The goal of this study was to determine the utilization of the Aspyre lung PCR assay for samples that would otherwise be reported as quantity or quality not sufficient for a large NGS panel due to various reasons outlined below. So for this study, a set of 63 PATH group non-small cell lung cancer clinical FFP samples were tested using the Aspyre panel. Initial pathology review was performed at PATH group, and samples were chosen based on the following criteria. First, quantity or quality not sufficient for Endeavor NGS panel. As Dr. Chandra and Dr. Gregg previously mentioned, that larger NGS panel require more quality amount of sample and tissue. Secondly, the tumor percent. And I'm going to talk about the Endeavor NGS panel in the next slide. So the tumor percent is required at 20% for the Endeavor NGS panel, which is another criteria for rejecting a sample, and also some limited samples where we know that we'll not get enough DNA to run a large NGS panel. So we reviewed those pathology samples at a PATH group, and those slides were provided to Biofidelity to run the test starting from DNA and RNA extractions. And test reports were provided back to PATH group for reporting, and the outcome of the Aspyre project was compared with our current NGS panel that we run at PATH group. So at PATH group, we run this PGDX Elio tissue panel, which we also call as Endeavor, which is an FDA-cleared panel for clinical sample testing. This is a DNA-based assay, including over 500 genes, and able to detect mutations, amplifications, and some translocations in addition to TMB and MSI. So these highlighted targets are included in the Aspyre lung assay. BRAF, EGFR, ERBB2, and KRAS are DNA-based targets, and ALK, MET, and TRKs, RET, ROS are RNA-based targets for fusion detection. Here are some examples of clinical results that we have obtained using the Aspyre lung PCR test using DNA. As you can see, that the assay detected various mutations of therapeutic significance, such as KRAS G12C, EGFR exon 20 insertion, and BRAF P600E. All these mutations have approved targeted therapies as indicated on the right side here. Example for KRAS G12C, sotorasib, and adagrasib are approved. And also we can see on the right that the amount of tissue that was used in this way were very limited, or either scattered or a very small amount of tissue. Here are some examples of clinical results that we have obtained using the Aspyre PCR test using RNA. As you can see, the assay detected various alterations of therapeutic significance, such as MET exon 14 skipping, ALK fusion, RET fusion, And all these alterations also have FDA-approved targeted therapies as indicated here. And also you can see that on the right that the tumors were either scant or not appropriate for endeavor or a large NGS panel. Here are the overall results that we have obtained using the Aspyre lung assay from these 63 samples. So we have detected mutations in EGFR, KRAS, ERBB2, BRAF, ALK fusions, RET fusions, and MET exon 14 skipping out of those mutations. And also I want to point out that for these 63 samples, the tumor cell percentage ranged from less than 5% to 95% with an average of 48.8%. The tissue area ranged from 1.5 millimeters square to 457 millimeters square with an average of 64.9 millimeters square. And we can see that 1.5 millimeters square is a very small amount of tissue. Necrotic samples. So the amount of necrosis range from less than 5% to 60% with an average of 21% for 12 samples out of these 63 samples with necrosis. And the turnaround time, it ranged from 1 to 3 days with an average of 1.6 days. So basically, and on the right, you can see that the data from Endeavor NGS assay. This is the historical data, and these are not the same samples that we have tested in parallel. And this is data from about 5,000 samples. And you can see that the overall prevalence of these mutations have a very similar trend. Like there we have a high amount of KRAS, and as you see here, and also note that the NGS panel cover much wider range compared to a targeted PCR panel. So I would like to discuss at last some of the advantages of the Aspyre clinical test from our experience for the lung PCR assay over a large NGS panel. First of all, higher sensitivity. It's validated for less than 5%, ideally 10% tumor cell content in the Aspyre lung assay versus 20% tumor cell content that we would need for the NGS assay. Secondly, less sample input. 20 nanogram of DNA per PCR reaction and 6 nanogram of RNA per RT-PCR reaction versus 100 nanogram of DNA requirement for the NGS panel. And also, as Greg pointed out earlier, Aspyre clinical test recently validated about 5 nanogram of DNA and 1.5 nanogram RNA input at about 10% tumor content. As we have discussed, shorter turnaround time, 1 to 3 days for Aspyre lung assay versus 7 to 14 days for a large NGS panel. And RNA fusions. So coverage of RNA fusions that are not included in a NGS DNA-based panel. So at the same time, there are also some disadvantages of a limited PCR panel over test over NGS assays, such as the limited mutations are covered by the NGS for the Aspyre lung PCR assay that may miss mutations in the non-covered regions. Also, a smaller panel cannot detect TMB and MSI, which can be detected by a large NGS panel. And also, a smaller PCR-based panel compared to a large panel can provide more therapeutic and prognostic information. For example, in non-small cell lung cancer, the targets like STK11, KEAP1 have prognostic value, and those are not included in a targeted PCR panel. So overall, from this study, we have found that the Aspyre PCR panel has a lot of clinical utility for samples that do not qualify for NGS-based tests due to variety of quality and quantity-related issues, or coverage or RNA fusions, which is limited in a DNA-based NGS panel. So with this, I end my part of the presentation, and I hand over to Dr. Chandra for the closing remarks. Thank you very much.
Thank you, Dr. Sarma, for that great overview. And so to summarize and provide you all with some clinical perspectives, this is a very important assay, and in our hands, it demonstrated very robust performance, especially on limited samples. That's a very, very significant advantage of this assay. And another very significant advantage is the rapid turnaround time. We get approached by our clinicians all the time, and they're always asking for when assay results will be done. And with an assay like this and an average turnaround time of 1.6 days, those test results not only improve outcomes, as you've seen here through numerous examples, expanding patient access to targeted therapies, but the rapidity of the test results also results in client satisfaction, client retention, and just overall enhances the relationship between the laboratory provider as well as the client. So as a result, we've been thinking internally about all of the different potential clinical applications and indications. And I've just listed a smattering here based on our results and our practical real-life findings. You could consider the assay in patients with early stage disease, albeit there's probably enough clinical evidence to champion comprehensive genomic profiling in patients with early stage disease. But remember, there are some clinicians who want those results rapidly, and there are many samples where you just do not have enough tissue for comprehensive genomic profiling. And so therefore, the assay would perform very well to potentially mitigate high QNS rates that exist in lung cancer. And those QNS rates, QNS stands for quantity not sufficient. Those rates range from 15 to 30% in patients with lung cancer. And so you could consider utilizing the Aspyre assay when there is low tissue volume or low tumor content, and or when another invasive medical procedure is just not clinically feasible for the patient. And then whenever there's a clinical need for rapid assessment, either if the patient has advanced disease at diagnosis, remember that patient who presented to Middle Tennessee in the ER, that patient had widespread metastatic disease, including metastatic lesions in the brain. This would be an assay that would be ideal for that setting. Or if the patient is not doing well clinically, or if liquid biopsy testing was done and it is not informative. It's very important to realize that just because you have a negative result on a liquid biopsy test, you need to interpret those findings in light of tissue sequencing results, which is considered to be the gold standard. And as we get into liquid biopsy testing, earlier and earlier in the diagnostic therapeutic continuum, you're going to have less ctDNA, and those tests are going to be less informative. So wanted to give you an idea of how we're thinking through things here at Path Group, and wanted to also thank you all for your time. And it's just been a great opportunity for us to share our experience. So with that being said, I'm happy to hand it over to Dr. Gregg or Bob McGonnell.
Dr. Chandra, thank you. And thanks also to Dr. Sarma and Dr. Gregg. This has been a really very, very interesting presentation. It sounds like this is an important advance and an important piece of a puzzle here that you've all correctly identified as being something that's plagued precision oncology for a long time. And as you rightly point out, Dr. Gregg has been the topic of numerous very good studies, not only in non-small cell lung cancer, but other cancers, but certainly in non-small cell lung cancer when the quantity of sample has become a major issue. With that in mind, Dr. Chandra, let me ask you, it should be obvious to us all why you would greet having an assay like this available to you as part of your armamentarium. Have you looked at other similar RNA, DNA stratification testing solutions? And if so, what particularly intrigues you as you continue to work with the Aspyre assay?
Well, we have looked at a few other assays, and Dr. Sarma, as well as some of our scientific team members, and there were advantages and disadvantages of some of these other rapid lung panels. What we thought was very particularly helpful with the Aspyre test was the low tumor content. While we haven't presented it here, the sensitivity of the assay opens up the door for potentially utilizing this assay in a liquid biopsy format. So those are some of the things, in addition to the just wonderful turnaround time and good. It's not comprehensive, but it's a very good coverage of the bread and butter molecular abnormalities that are needed.
Thank you very much. And I'll direct this next question to Dr. Gregg. We've got a good number of people on the call today who are wondering about how they get this test. Does this need to be sent out to BioFidelity's laboratory to perform, or will one be able to bring this test in-house, if not now, but eventually so?
Well, great. Thanks for that question, and great question. So we talked today about BioFidelity's laboratory developed test that we have in our North Carolina lab as a CAP/CLIA, which is CAP/CLIA certified. But in addition, we do have the reagents available per RUO to individuals who want to go and insource this test into their own laboratories. And so that is also available, and we can support that.
Understood. And of course, as we mention RUO products and lab developed tests, we want to be very careful to realize that these will not be kitted tests. These will be the reagents available for what will be, a considerable in-house development, right?
Correct. This would have to be validated in your own laboratory. Yes.
Very good. Dr. Sarma, you have, with your background at Path Group, you have superb comprehensive genomic profiling tests. In fact, we've written those up. We've discussed them before. Let's get a little more color in where the biofidelity test will be fitting in a certain sequence. We've mentioned the quantities of material that you might get in a sample and the difficulty there. But I'd like to mention just for a moment the eagerness that clinicians have, and also increasingly that patients have, to be gotten on therapy very, very quickly, perhaps prematurely, before there's an adequate diagnosis. This is a heat that comes on people here. We see it also in infectious disease, as we all know. Let me ask you, Dr. Gregg, first to comment on that, and then I'll ask our two clinicians from Path Group.
Can you exactly what was the question?
The question is, we know that when patients get a serious diagnosis of a lung cancer, there's an eagerness for treatment to begin as soon as possible.
Correct.
And of course, Keytruda and other immunotherapies are, of course, top of mind in many cases. It's a very public drug, but of course, we're arguing that you really need to do an adequate test for the actionable mutations that other targeted therapies can offer you. And is this in part one of the attractions of this test, do you think?
Yeah, I think this is really one of the real critical aspects of our test is the fast turnaround time. And talk to many of my oncology colleagues is you absolutely want to get your patients on the best therapy for themselves. And to do that, you need to do molecular profiling. It's not getting the patient on the treatment fastest. It's really getting them on the right treatment. And by going and being able to go and get testing done in 2 days, we're able to go and get that information into the hands of clinicians so they're not put in this predicament of having to wait and wait and wait and wait and having their patients get sicker, and then sometimes having to make those difficult decisions to start treatment and perhaps treating those patients with the therapy that may not work as well as the potential targeted therapy. So I think it's absolutely critical to get that molecular information before you start any treatment. And I think I did demonstrate kind of in that first slide that patients that get those results before treatment do so much better. And so this is just another tool for oncologists to use to get these test results back into their hands faster. And it's us pathologists. And what I love about biofidelity is that, as we talked about the previous question, is this is a test that can be sent out to biofidelity and our CAP CLIA lab under an LDT, or this test can be utilized by a pathology lab, and we can go and ship them those reagents under RUO so that they can do that testing themselves.
Very good. Dr. Sarma, is this one of the great appeals as you see it? Because I know you have an enormous reach at Path Group. You've got many clinicians who will have, quite frankly, various stages of sophistication about these kinds of molecular tests and genomic profiles. Is that correct?
Yes, that is correct. And also, like a test like this, where we already established that we basically that amount of tissue or the sample is insufficient, or quality or necrotic or quality is not good, and which we're basically going to say, hey, quantity not sufficient, or we are unable, will not be able to provide a result for the broader NGS panel. And something like this is extremely useful in that. And also at the same time, I also would like to point out that, I think we talked about immuno-oncology targets, and if you see the results from that assay, about 63% of those were no mutation detected, and a portion of that would probably have got high TMB or high MSI, which would qualify them for a drug. So that is also something that we also have to, that the patients who are not qualified or nothing is detected, what else they qualify for. So that is something, an area to definitely explore, that a mutation not detected means what next for that patient.
Very good. Dr. Chandra, I want to come to you with another question that's much on our minds. We're beginning to see targeted therapies for what you might call pan-cancers, all of which have different lab values that essentially indicate that the drug will be affected. I mean, right now in HER2 and low HER2 is all the rage in discussions by pathologists, as we all know. Do you see a role for an assay like this in some of the pan-tumor indications where the, measurements are needed and needed to be made quickly?
I do. I believe there are certain alterations like NTRK and RET alterations, Bob, that when they are detected, it doesn't matter if you're dealing with a lung cancer or an advanced colon cancer. There are pan-tumor FDA approvals. So I do know that this assay is optimized for lung cancer, but I see where you're going with this question. This could potentially open the door, and I'm sure Biofidelity is giving some thought to this, to a rapid pan-cancer assay that looks at all of the common alterations, especially the ones that have pan-tumor approval. But I will also say that this assay will continue to need to be supplemented by IHC to assess for PD-L1 expression, which is optimally done by IHC, or HER2 protein expression. That FDA approval is in patients with 3+ protein expression, the pan-tumor approval. So we have to keep that in the back of our minds as well, and just understand the advantages and limitations of testing and where to utilize comprehensive testing to optimize patient care.
Thank you, Dr. Chandra. Dr. Gregg, I'm going to give you the last word. Dr. Chandra suggested that pan-cancer indications could be a very important avenue for the application of the biofidelity test. Would you care to comment on that?
Yeah, I think you're exactly right. And as you can see, as I briefly went through the technology, that the technology is quite amenable to the kind of this fear of pan-cancer indications, and we will be moving towards that with other products in the future. And you can imagine, just looking at our current product with lung cancer, that many of those alterations that you see, for example, RET, are already kind of in this pan-cancer continuum, so that we exactly feel the same way, that this can be very important, and that we'll build products for those problems. And we're here to solve the big problems in diagnostics, or at least help for these big problems in diagnostics, so that we can get this really important molecular information into the hands of patients and oncologists, so they can make the best treatment decisions for those patients to get the best clinical care for them.
Thank you. Thank you very much for that answer and that final word. I know we've had questions about some other tests that have come from our audience. I'm going to suggest that you reach out to a biofidelity spokesman or staff member to help you with some of those individual comparisons, because you can take that much more time to develop your question and hear answers to that. But with this, it's about time to wrap up. So I want to begin by, of course, thanking our speakers, Dr. Jeff Gregg, Dr. NayanJ Sarma, and Dr. Pranil Chandra, the latter two of Path Group, and Dr. Gregg, of course, at the University of Nevada Medical School, but of course, the Chief Medical Officer for Director, Vice President of Medical Affairs at Biofidelity. Thanks to all three of you. It's, of course, we're very, very grateful to Biofidelity, and we're very grateful to have a chance to, in some ways, introduce them, I hope, to many of you, because you're going to see and hear a lot more about them now, in the near-term future and in the later-term future, for that matter. Finally, I want to thank all of you who've taken your time out of a very busy day. We know things are hectic. And to join us today, we really do enjoy bringing these webinars to you. We're very grateful to our sponsors, such as Biofidelity, and grateful to all of our wonderful speakers who bring you such up-to-date information, so well presented and so clear. You'll have a chance to review this once we post this. So just to wrap up one more time, thanks to Dr. Sarma, thanks to Dr. Gregg, thanks to Dr. Chandra, thanks to Biofidelity. And thanks now to all of you in the audience. And with that, I'll bring today's webinar to a close.